It's a pleasure to be able to join you today to talk a little bit about what's happening in dosimetry for radionuclide therapy. It's a situation where we are at the very beginning, I believe, of a long journey in terms of refining and improving our techniques. We know already that we're having some success with the new range of radionuclide therapies, most notably the lutetium-labeled peptides for neuroendocrine tumours and for prostate cancer. And I think this is really just the beginning of a number of different radiopharmaceuticals which are going to become available in the next years for radionuclide therapy. So today I want to just go over some of the methodological and technical aspects around the physics of this and give you some insight as to where we might be heading for the next generation of Theranostics. To set the scene for our discussion, let's just have a little think about where we are today in terms of our delivery of radiation for the treatment of cancer. At one end of what I'll call the spectrum here of treatment options, we start with little or no patient-specific information in terms of defining our treatment. So it's a one-size-fits-all approach, and the classical example of this would be the treatment after thyroid cancer surgery with radioablation using radioiodine 131, where we use a fixed dose, 2, 4, 6 gigabecquerels without a whole lot of evidence. And we don't tailor this in any way to the patient. We get a wide range of responses. We're probably over-treating in some people, under-treating in others, but on average, it's a very effective therapy. So there's very little information that we need to do that. When we order the dose, we don't even know much about the patient themselves. At the next level up, you might have minimal patient-specific information, for example, simply the height and weight, as is done in a lot of chemotherapy regimes. We have minor adjustments to dosing, can be done on the day of treatment, doesn't need a lot of input from people. We don't have a lot of data to make an informed decision on the dose, and the information used may not be relevant to the disease burden. For example, if we just go on the BMI, or body surface area, for example, as is done with the simplest way you can calculate the dose of Cerspheres required to treat metastatic liver cancer. So there's a little bit of information there, but not very much. And then really at the far end of the spectrum is where we are today with our advanced radiation oncology treatments. So we've got highly specific dose prescriptions, image-guided treatments, carefully defined planning treatment volumes. However, the downsides are it's very time consuming, requires imaging and other investigations beforehand, requires the radiation oncologist to sit and plan these out. It's obviously getting better these days with atlas-based techniques to segment out organs at risk and sensitive tissues. But again, the problem with the radiation oncology approach at the moment is we really can only treat a limited number of targets at any one time because of the technical aspects of defining the fields and also the range at which we covered. So the metastatic setting, for example, is not amenable to radiation oncology. So we see that as we traverse the spectrum from little information to highly specific information, more and more information, and I should add time, is required to come up with the treatment plan for that particular patient. So what's the aim of thinking about better radionuclide therapy planning, going beyond the fixed dosing that we use a lot of the time at the moment? Well, if we tailor the amount of radionuclide therapy delivered to the individual patient, we can then start to modify it based on, for example, tumour burden or the size of the patient. It seems very simple, but we don't do much of this at the moment. What we're trying to do with this better planning would be to maximise our cancer cell kill while minimising the toxicity to any normal tissues. And we know that we get a lot of physiological uptake in other tissues and organs when we're treating with our radionuclide therapies, and we'd like to keep that to a minimum. For example, renal toxicity is something that we are very concerned about with the lutetium-based peptides. We'd like to be able to treat to a prescribed dose in grey, not in gigabecquerels, but to say we want to give a certain number of grey to the tumour, and that would usually involve some sort of a workup procedure. Imaging would be involved, and often we're looking at the biodistribution over time. And ultimately, where this is all heading is towards better outcomes for the patient, of course. What are the tools that we would require to better inform our radionuclide therapy planning? Well, most of the radiopharmaceuticals that we would use would be changing over time. They would be dynamic. There would be some sort of biodistribution which is altering. And a lot of the radionuclides that we would be using for therapy have longer half-lives. And so that would mean that we would need the workup studies done with imaging traces that have longer half-lives as well. And also you would want to administer those radiopharmaceuticals in the workup for planning under the same conditions as you would for treatment. So, for example, we use amino acids to protect the kidneys from renal tubule damage. Sometimes we use radiosensitizing chemotherapy at the same time as we're giving the radionuclide therapy. So if you were really trying to do planning under the same conditions as you will for treatment, you would want to be doing those as well, and clearly this adds to the complication. I think the thing that we really do need, and where I've been doing a lot of work, is really in the quantitative 3D imaging. We need to look at the whole body, and we need to look at fully quantitative SPECT or PET. And then we'd like to take that image data and convert it into dose maps. So we're not talking about organ doses, so single value averaged over the whole organ. We'd like to look at individual voxel-based doses, and using the software that we have to turn that radionuclide distribution over time into maps of absorbed energy or dose in grey. How can we go about doing this radionuclide therapy treatment planning? Well, if we think about the analogy with the radiation oncologist, they do their CT simulation scans, so they have a CT scanner and they image that part of the body that they're going to treat to define the structures that are there. They then map out their fields, and then the prescription is fed to the linear accelerator to deliver the dose that they have prescribed. How would we accomplish the same sort of treatment planning? Well, I think there are essentially two approaches. The first one is more involved, and it involves performing a planning study with a suitable long-lived non-therapeutic radionuclide, ideally under the same conditions as for the treatment. So we do something like this at the moment for SIRT treatment, where SIRT is a radioembolization, so there's no redistribution over time. The workup scan uses MAA labeled with technetium in a intra-arterially delivered dose in the same approach, the same location that you think you will be treating the patient with the Y90 SIRT spheres. So that's a very simple example where, because we have no temporal component of this, it's delivered and it stays in place. If we think about more peptide-related therapies, there will be a pharmacokinetic change over time. There'll be an altering biodistribution. We'd be looking at the uptake into the tissues for treatment, and also the uptake of the tissues that we're trying to protect. So that would necessarily involve imaging at a number of time points with a long-lived radionuclide that would be suitable, whether it's PET or SPECT. This obviously involves much more cooperation from the patient. So just to plan them, they'll have to attend the department a number of times. For imaging, we'll then put this through the software program and then extrapolate from the imaging radionuclide to what the therapeutic radionuclide dosimetry would be, and then derive the dose that we want to give. The simpler way is probably just to give a standard dose, as we do today for all cycles, at the first treatment cycle, and then using the imaging that's usually available from the therapeutic radionuclide, calculate the dosimetry from multiple imaging points, and then individualize the subsequent treatments based on that information. So this is not terribly difficult to do. Again, it does require a bit of cooperation from the patient, and we've certainly used this sort of an approach at our department, where the patients are imaged on the day of therapy, the following day, and then at a later time point, say day 3 to day 5 after the therapy. And that gives us enough data and time points to define the time activity curves for the different tissues and organs. What options do we have to do this? And this is sort of interesting because if you think about the first approach, if you're doing a full planning study using PET with its fully quantitative potential, then actually you're really limited to some quite exotic PET radionuclides, copper-64, 12.8 hour half-life, yttrium-86, zirconium-89, iodine-124. Note, of course, that you cannot use gallium-68 or fluorine-18 if you are looking at something that has a biodistribution that's changing over days because of the very short half-lives of those. So the two radionuclides that we're most used to using in PET are of no use to us at all for the treatment planning aspects of radionuclide therapy if we wanted to do that. In SPECT, we have some reasonable options. We've got indium-111, iodine-123. We could use iodine-131, although we're concerned about the stunning effect that we know about. And something I've been interested in, gallium-67, which is fairly commonly available and not terribly expensive. But we can use the chemistry that we know for all of the gallium-68 labeled peptides and substitute 67 and use that for planning. And we've certainly done a study with that, and I'll show that a bit later. Again, technetium-99m with a 6-hour half-life is probably not suitable for doing a workup planning study. What about the second option? Well, in PET, we really don't have that many therapeutics that we would have emitting a positron as well as a beta minus. Perhaps the only thing we've got is yttrium-90 with a very, very small pair production positron that's emitted that you can image, but really it's not useful for systemic evaluation. It's only when you've got a localized distribution, say within the liver, that you could use yttrium-90. So there aren't many options there for PET, but of course in SPECT, I think it's fortunate that many of the beta emitters that we use do, like many beta emitters, have a subsequent gamma emission, and we can image that. So the ideal pair perhaps for this is the copper-64 PET for imaging, followed by a copper-67 for therapy, which again itself can be imaged. So we really do get a lot of information from that. Iodine-131, of course, we can image that afterwards, although it is a high-energy photon and the spatial resolution is fairly poor. Lutetium-177, in many ways, I think is almost ideal because it has the beta for therapy followed by a fairly low photon fraction for the gamma emission at 208 keV, and that's pretty well imaged and doesn't produce too much of a radiation safety issue, so that most of our lutetium-177 patients can be discharged back into the community on the day of treatment after 3 or 4 hours, even though we might have administered them up to 8 or 10 gigabecquerels of lutetium. The peptide is eliminated fairly quickly from the body, and the low photon fraction means that they're not a large exposure risk. So that's quite ideal. You could use phosphorus-32 and yttrium-90 bremsstrahlung imaging, although that's less than ideal because it's rather poor spatial resolution, and you'd much rather image photons arising from the nucleus of where your labelled molecule is. So it's interesting to look at this really because of the traces that we are most used to using, the gallium, fluorine and technetium, don't have much of a role to play in any of this. However, it does emphasise the role that SPECT has in imaging the radionuclide therapy after it's administered, and I think this is going to be something we're going to use a lot more of in the future. Let's look at some of the tools we have available today for quantitative imaging. If we go back to the start of our lutetium therapies back in 2013 or so, this is the standard that we were using. We have here the gallium dotatate PET that you can see. Nice high resolution distribution of our radio labelled DOTA octreotate, showing a lot of metastatic disease in the liver, primary in bowel. And this patient then goes on to therapy, and you can see here time after injection, immediately after injection, already got a lot of uptake, and it's still a fair bit of blood pool. A couple of hours later, you can see that it's really being cleared from the body but retained in the lesions. Then the next day and a couple of days later, we were able to look at the retained activity in the body fairly readily and able to validate that quite nicely using planar gamma camera imaging. These are geometric mean images corrected using a transmission scan, Cobalt 57, and we were surprised that this really did give very good estimates of the radioactivity in the body. We were able to do that at the first time point before any of the radiopharmaceutical had been eliminated from the body to check that, and so we were using this extensively for the first couple of years to look at the retention and get an idea about the pharmacokinetics. But that's still planar, and there's a lot of issues. It's hard to estimate the dose to the tissues that you're targeting with this approach, and you'd much rather use a 3D technique. If you can use PET, and I've mentioned copper-64 with its longer half-life of nearly 13 hours, this is now the clarity agent sartate, which is a chelated octreotate, so still targeting somatostatin receptors as in the previous image, but this time we're using PET to do the planning, and this is with copper-64. So here you can see the distribution at 1 hour after administration, with regions now being defined as volumes of interest in 3D, and these can be transferred onto subsequent images. So here we are at 4 hours and at 24 hours, and you're still getting good image quality out to that time point. And so now we're able to look at the biodistribution in lots of different organs over time, and from that generate the dosimetry estimates. That then can be converted to what the dose would be estimated for if we were using the therapeutic analog of this, copper-67, as a theranostic pair, and so we're able to then individualize the dosimetry using this. Really an almost ideal situation, I think. We are now starting to do the same sort of work with 3D SPECT as it becomes increasingly quantitative, with both GE and Siemens offering systems that have quantitative capabilities. So here's a study that we did with a company called Mnemonic at Macquarie University here in Sydney, and this is a labelled monoclonal antibody, and this time we used the gallium-67 to label it, to look at the biodistribution over time. And while these are planar images, we were doing quantitative SPECT of a single bed position at the time as well. And you can see here the excellent image quality you're getting at all these time points out to a week after injection. We're still seeing very decent image quality in liver and other organs. So this has now become our standard to use a whole body SPECT CT to do the time points. So really it's very, very similar to what you see in PET, but with the proviso that we know that the spatial resolution is not as good, and that's something I'm going to talk about more throughout this talk. However you get that quantitative information, you can then take it into the various software packages, and there are a large number available. The aim is to really segment out the organs that you're interested in, here the kidneys, and then look at the uptake in the kidneys, and from that derive the dose maps. What we're looking at is the change in the uptake over time as it's eliminated from the body, and then using those curves at the voxel level to estimate what the absorbed dose is in that particular area. Of course, we'd like to do this also for the cancer tissues, and with SPECT we do suffer a lot from the limited spatial resolution. So that's been a little bit elusive up till now. I would say that we've been able to use PET to do these estimates, but again we're limited to what PET traces we can use to do long-term biodistribution measurements. Typically copper-64 is the one that we've had available to us, but in SPECT we've been not really able to estimate the uptake in small tissues very well because of the poor spatial resolution. So just an example, just to show you how we use this. This is treatment of a neuroendocrine tumour, 39-year-old female who's well known to many of us. She had a pancreatic primary. At surgery, when she had her Whipple's procedure in 2011, the Ki-67 in the pancreatic net was 1%. But when she came back for systemic treatment and had metastasis removed from her liver surgically in 2014, it was now 30%. So the disease was evolving and changing over time. So she got a standard 8 gigabecquerels delivered over 4 cycles. And you can see here on her baseline dotatate, she's got a lot of disease in her liver, but also there's one vertebra which is very, very hot as well. And so we're interested in looking at the dose there. Not a small structure, so we could get a good estimate of the lutetium dosimetry for that. So we're using, this is the Dosisoft program. We use that to look at the voxel-based dose. And so here's that dotatate image again. Here's this corresponding dose map from lutetium 177. So we can now actually work out the dose here, and we figured that the dose was about 5.6 gray on average throughout that vertebra. And then we look at her when she came for her second cycle. We again imaged her, and we had no uptake in this now somewhat sclerotic looking vertebral body. And she'd had a complete response in that area, as she did in a lot of her liver lesions as well. So even though that seems like a small dose, we obviously had a big impact there, and she had a particularly radiosensitive clone that was responding extremely well. So that's using our intensive sort of imaging. This dose map would have involved 3 time points at least, and then using the software to generate these dose maps. You can see we're estimating doses also in the liver lesions as well. Here's another example. This is I guess a simpler example, because this is SIR-spheres. So this is a 59-year-old male with metastatic colorectal cancer. We prescribed, based on the MAA planning scan and the package insert that comes with the SIR-spheres, 2.1 gigabecquerels. He had a tumour burden of about 26%. And I'm showing here his baseline FDG, so you'll recognise this in coronal sagittal transverse section. He's got a number of very active FDG lesions. When he was treated, this is the PET Y90 CERT scan. So this is not planning, this is actually showing where the dose has gone. And you can see, because the SIR-spheres are delivered intravascularly, intraarterially, their distribution reflects the blood flow, and these were obviously very vascular lesions, and you can see terrific targeting in most of these lesions. And so we were able to work out the doses for this as well. And he had a terrific response, as you can see in the follow-up FDG, which we do about 2 months later on the bottom line there. We got average lesion doses in the range of 16 to 73 gray, while keeping the dose to the normal healthy liver at an acceptable level. We try and keep this below 30 gray and ideally below 20 gray. So again, this is voxel-based measures that we can just use a cursor or a VOI to look at what the average dose is in all of these lesions. So that's a bit of the actual use of it. From data such as this, we were able to generate our dose response curve and start to get an idea of how much dose in grey from Y90 that we need to deliver to a lesion to affect a metabolic response such as this. We think we need about 50 grey, and over 50 grey we expect to see around a 50% reduction in the FDG uptake. Less than 50 down to 30 grey, it's variable, and below 30 we really don't see much of a response. So we're starting to get an idea of what we're aiming for. We need to get that amount of grey to the lesion to affect a metabolic response. But how can we really estimate the radiation dosimetry with any accuracy? And I want to talk a little bit now about the limitations of the spatial resolution from the gamma camera. So I've said that we don't have many options available to us to use PET to do treatment planning. The one I'm showing here, copper-64 sartate, is one of the only ones that we have ready access to. This patient has multifocal unresectable meningiomas, and they often express somatostatin receptors, and so you can use lutate or sartate to target these for imaging and for therapy. So here's an example of the PET scan, the workup scan, 4 hours after injection. This is what the uptake in the lesion looks like. There's one here, and you can see another one here. That's the pituitary, so that's not a tumour. But if we look at the corresponding, what we're used to, the corresponding scan of the therapy, this is now copper 67, so this is the treatment. That's the sort of image that we get due to the very poor resolution that we see with a medium energy collimator imaging the 208 keV photons from, the 185 keV photons from copper 67. So I'm sure many of you are used to looking at images like this post-treatment, and the point about this from a measurement angle is that we cannot really get a decent estimate of the dose delivered in such a blurry area. When we did some investigations of the spatial resolution for our gamma cameras with medium energy collimation at the 200 keV or so level, we were a little bit surprised and disappointed to find that the resolution of that device is around 20 to 22 millimeters full width half maximum. If we talk about technetium, that value is probably about 10 or 12 millimeters. So we know also that to get full or close to full true recovery of the concentration, such as we're seeing here, in an object, that object needs to be about 2 to 3 times the size of the spatial resolution. So if we've got 20 millimeter spatial resolution for the gamma camera, that means that we need an object that's 40, 50, 60 even millimeters in size before we even start to get close to full recovery. So we've got a problem there. If we're talking about lymph nodes or small metastatic deposits and trying to look at the dose that they've received, we're just not going to be able to do it. I point out also in this example that there's very little background you can see here in the brain, so we've got nice contrast here. But if we're talking about this size lesion in a liver where there would be some physiological uptake, it would be even harder in this circumstance to define what the actual activity is. So a lot of this came to the fore for us when we started doing our early SPECT dosimetry. We had quantitative SPECT available for lutetium. We started looking at the dosimetry, and we were really disappointed to find that we were thinking we're only getting a couple of grey to the lesions, and we thought, well, we're seeing a response. We're only giving very small doses, it seems. How is that possible? It turns out, I think, really that we're massively underestimating the radio concentration and the uptake because of the partial volume effect. So that's been a major focus for us in recent times. And my PhD student Harry Marquis has done some fantastic work in developing new reconstruction methods to try and address this. And we asked the question, could we use the PET reconstruction with its good spatial resolution to in some way guide the SPECT reconstruction as an a priori piece of information? And we call this a theranostic reconstruction because we're going to use the PET workup to guide the SPECT reconstruction. And we're using the same radiopharmaceutical in each reconstruction, so that should be okay. The biodistribution should be quite similar. If we control the other physiological factors such as the amino acids and things like that, you could even make it better. And we're sort of talking about this, we call it a SPECTA reconstruction, so single photon emission computed theranostic reconstruction. So we're taking that theranostic paradigm where you use it for imaging and for therapy at the pharmaceutical level. We're now using that same approach for the reconstruction process. We're using an algorithm that's got this long name of hybrid kernelized estimation maximization that was developed by a guy called Daniel Deida in the UK. He's been working with the STIR group. STIR are a iterative reconstruction open source software group that's funded by the EU and as a consortium across Europe. So what we've got here is a gallium-68 PET scan of a phantom. You can see you've got good recovery indicated by the red color in these spheres. This is 37 millimeters in diameter. Dropping down to the little one is 10 millimeters. This is 17 millimeters or so. And you can see that the partial volume effect decreases the apparent concentration as you get to smaller and smaller spheres. But if we could achieve this sort of spatial resolution with SPECT, I think we'd be very happy. So what standard lutetium imaging, this is what we would get. This is our quantitative SPECT that we've been using for a long time at Royal North Shore, and you can see that we get close to full recovery in that 37mm sphere, but in none of the others. So if we look at some better reconstruction approaches, we can use resolution modeling. Most of the vendors have this available now with lots of different fancy marketing type names, but really this is resolution recovery, resolution modeling. At 5 iterations of the OSEM algorithm, you can see now you've started to recover the concentration in this second sphere reasonably well, but none of the others are improved too much. So you can push this further by doing more iterations, of course, and now you're starting to see you're getting good recovery down to around this level. But the penalty that you pay, you can see in the background, is that the noise is increasing, and that's a characteristic of the OSEM type iterative reconstruction. The further you go, the more iterations you do, the more noise you tend to get. And so obviously you'd like to try and find somewhere in between these two numbers of iterations where you've got good recovery but you're not making the noise too much worse. But this spectre reconstruction, using the HKEM approach, using the PET to help guide the SPECT, gives us this reconstruction. So you can see that we're now getting very good recovery in a number of the spheres. We still see the smaller sphere. It's actually very PET-like when you look at that image. If you compare the PET with the spectre, they're very, very similar, but we really do have good control of the noise in the background as well. Now, of course, this is a little bit complicated. You need a PET to match the SPECT, you need good image registration and things like that, but at least I think it shows that we can address some of the spatial resolution limitations from PET in SPECT, and the benefit of that would be that we would get much better estimates of the dose in smaller objects. We've been able to use this in a study that we've been doing with Clarity Pharmaceuticals, looking at the copper 64, copper 67 pairing of a Theranostic attached to sartate. And here's some clinical examples which I think will nicely show how this algorithm has got potential. So this is the PET workup study. You can see the nice uptake, and I showed you these images before. Here is the limited quantitative SPECT, limited because of the poor spatial resolution. This is copper 67 now. Previously I was showing in the phantom lutetium 177. This is now copper 67, the therapeutic. This is the OSEM with resolution modeling and 40 iterations. We start to get good recovery, as you can see here in the lesion. But notice, as we saw in the phantom study, that the background area starts to get noisy. And if we were looking, say, at lesions in a liver again, this would be a very noisy background to be working with. The spectre reconstruction actually does a good job recovery. So this is guided by the PET scan here. This is how the images look. You can even see the other lesion towards the front of the skull here, but notice also that the noise is nowhere near as bad. I hope that comes across in the projection as well as I can see here on the screen. So we think this has got great promise in overcoming one of the major limitations in getting good dosimetry based on the therapy itself, imaging the therapy, and that has been to overcome the partial volume effect. I want to turn our attention now to a little bit of a discussion about how the radiation is having an effect and how we need to understand this a little bit better. So if we consider external beam versus radionuclide therapy, I think it's a really useful way to consider how radiation therapies work. There is so much known about external beam radiotherapy. There are textbooks on all this, and if you look at the discussion and the content of all of the textbooks on radiation therapy, they tend to be all about external beam radiotherapy. So let's just look at the differences between external beam and radionuclide therapy. External beam radiotherapy is given at very high dose rate. This is grays per second. It's an acute irradiation that takes place over a few seconds. They use fractionation heavily to try to protect normal tissues better and minimize late effects and maximizing the cell kill and the early effects. It's generally megavoltage X-rays that are being used, 3 MeV, 6 MeV, that sort of level. It's really useful for a minimum number of targets. It can't really address metastatic disease very well. And the likely cellular effects are delivered in the acute setting. So there'll be necrosis and a mitotic catastrophe in the cell, leading to cell death. It's likely that the acute high-dose radiation causes massive disruption to the mechanism of the cell, and that starts an apoptotic cycle occurring. In contrast, radionuclide therapy in many ways couldn't be more different. It's a very low dose rate. It's a continuous irradiation over days to weeks. It's often given as a single dose, or we use a single dose 8 weeks apart. That's not really a fractionation as such. We've got different particles with different ranges. We've got alphas, we've got betas. You might even add Auger electrons in there. It's mostly suited to the metastatic setting with molecular targeting. And the likely cellular effects are to induce apoptosis by the loss of a clonogenic potential. So when the cell comes to divide the next time, it's not able to. So rather different to the external beam situation where you cause massive damage in a short amount of time. Now I've got a little cartoon to show you of what I think of as external beam radiotherapy. I think external beam radiotherapy is like this. You've got a whole lot of flamethrowers around the target, and you fire at the target from lots of different angles to try and kill the target. On the way, of course, you're going to do some damage to the other tissues, but the flamethrowers are coming from lots and lots of different angles. The contrast I see with radionuclide therapy is that we've got a bomb that we've placed in the target, and then it explodes and releases locally. And so we would hopefully minimize the damage to the other tissues around it. And I think in decades to come, potentially people will think back and think, why did you ever think it was a good idea to fire radiation through normal tissues to treat a single target? Well, of course, we know it's very effective and you can minimize the side effects, but it does complicate it by needing fractionation and those sorts of things to try and minimize any side effects from the radiation. So we'll see later on that radionuclide therapy's future is looking like it's going to be quite big. How does the radiation interact with the cells? Well, we've got initially, of course, the radiation causing some single strand or double strand, hopefully break, and then we're going to have the early responses. So we get some early cell death. This will be mostly what we see with the radiotherapy because we've sort of disrupted the cell to a large extent. But the mitotic catastrophe that we see here means that the late cell death, this is unable to reproduce and eventually dying, and that's more going to be what we're doing with the radionuclide therapy as opposed to what external beam's doing with the early cell death. So it's a long, slow death, if you like, by strangulation that you can't reproduce anymore. What I think we need really is a deeper understanding of the radiobiology of radionuclide therapies, and so in recent years we've set up a lab to do this in our research institute, and our first paper shown here with Yasser Gholami as the first author looked at comparison of external beam radiotherapy against yttrium-90. So we took colorectal cancer cells and we mixed yttrium-90 into the media that support them. We irradiated them for 8 days and then assayed how many cells had survived. And we compared that with external beam radiotherapy. And so what we're showing here is the dose that was delivered. And these doses were comparable from a single dose. This is not fractionated from the external beam. It's a single dose of radiation on the LINAC compared to the high dose rate yttrium-90 or the low dose rate yttrium-90. And you can see obviously that the external beam has much more impact on cell kill than the low dose rate, the lower doses coming from over longer periods of time coming from the yttrium-90. So what we think is really going on here is that the dose rate is so low from the beta emission from the yttrium-90 that you can affect a single DNA strand break, but there is appreciable time for that to be repaired by the cell before another DNA strand break in the same region, because you're obviously trying to get a double strand break. Now, if you're delivering that radiation over seconds as EBRT, the chances of double strand break are fairly high within a short period of time, certainly much shorter than the repair time available to the cell. Whereas with the lower dose rate delivered over days and weeks that we have with yttrium-90 and other radionuclides, there is more chance for the cell to repair that single strand break before the next single strand break, and so you don't ever get your double strand breaks. We published this back in 2017, and then just last year the Oxford Radiobiology group published a very similar results. This is external beam shown here on cesium-137 irradiation at high flux rate compared to yttrium-90. So we've got very, very similar data coming out from the Oxford group asking the same sort of question. Interestingly, two of those, Dr. Boone Lee and Dr. Nadia Falzoni, have now relocated to Australia, and so we've got some good talent in the country looking at radiobiology, and I think this is going to be something we're going to do increasingly. We don't have at the moment in our own institution the ability to do this in small animals, but certainly at the cell level we were able to do quite a bit of work in this area. So we need to understand these mechanisms better, and what we're learning from these experiments is that there probably is a critical dose rate under which we won't get a good consolidated effect. We need to have a higher dose rate from our radionuclide therapies. And the Oxford group have also shown that they've looked at what is really the biological effective dose. So not just the dose in grey, but how does what does that achieve and biologically? And this is known as the biological effective dose. And if we just look at, these are three different cell lines. If we look at the bottom one there, what we will see is that at what we calculate to be a dose of 60 gray, biologically that's roughly about 30 gray, and this obviously differs for different cell lines, and so there's no hard and fast rule, but it appears that the biologically effective dose that we get is somewhere around 2 to 4-fold less than what we think we're giving in terms of sheer energy deposited in the tissues, which is what the grey is. So starting to understand and unpick this a little bit better as we go forward. The other thing you could think of doing is to block that DNA repair by giving a PARP inhibitor, and this was a study from a couple of years ago by the Erasmus group, who have done a lot of work in this area of Theranostics and peptide receptor radionuclide therapy, and so they looked at giving olaparib at the same time. This is in cell culture, and this is with lutetium dotatate, and you can see here that as you added from no treatment or just giving lutetium alone to when you've added it with the PARP inhibitor, you start to see that you're having a massive effect in terms of limiting the ability of the DNA to repair itself. So it may be in the future that we use something like olaparib at the same time as we're administering the PRRT to try and overcome or mitigate that dose rate effect, where we need to stop the single strand DNA repair happening. Another thing to help us understand a bit better what's going on, I think is very interesting, again from the Oxford group working with the Erasmus people. There's a well-known assay that's used to look at cell survival called the gamma H2AX assay, and essentially when you have double strand breaks, the gamma H2AX is liberated, and you can stain for that, so they're using immunofluorescence. Here's examples. So this is DAPI, so showing here DNA density, and this is the gamma H2AX signal from increasing amount of radiation to the cells, and you can see that essentially you can use this assay in cell culture as a dosimeter, so you could work out the dose response by the amount of immunofluorescence you're getting from the H2AX assay. So what the Oxford and Erasmus people have done, which I think is absolutely fascinating, is that they've taken this to an in vivo assay now. So this was shown last year when we could all meet together at conferences at the ANZSNM, and this is now imaging with gamma H2AX in an animal model. So here's lutetium, and here's the gamma H2AX labeled with indium-111, and so now what we've got is an in vivo dosimeter. So here we could be treating people, say, with an alpha emitter, which are not terribly well visualized with the gamma camera or any external detectors, but you could then chase that with an indium gamma H2AX probe, and you would be able to look at dose in the lesions subsequently. So I think this is really fascinating and interesting work coming from these very, very prolific groups overseas. The other thing, of course, we have to do is be practical. And so we're looking at simplifying our imaging protocols. We spent our first 5 years or so at Royal North Shore doing intensive imaging on just about everybody that we could, and that gave us a lot of very valuable data, very unique data sets, I think, but it really is a big burden on resources for the patients, for the staff, and for the imaging instrumentation. So a number of groups, including our own, have looked at simplifying this down to a single imaging time point. I guess the difference at the moment is that everybody picks a different time point as being optimal. We thought that 24 hours in this paper would work well for lutate. These people think that 96 hours is probably the best place to image, and again, Price Jackson and others have got other time points in mind for generating the dosimetry, but all of us are starting to look at this. I think the good thing is that we've got the data in our hands now to potentially answer this question because of what we've been doing for the first 5 years or so of our treatment centre, and that is acquiring all of the data that you could possibly need to see how you could simplify that. So that's something we are addressing, and hopefully that will result in a standardised protocol that we can then roll out and many people could use to try and get dosimetry for their patients on a very simplified protocol. So where are we with Theranostics today? This is what we have available at Royal North Shore in Sydney. It's not just limited to lutate and PSMA, for example. If you think about it, thyroid cancer, we do, that's like a theranostic using iodine 123 or 131, MIBG, obviously dotatate, and you can see all the others here. I think the point about this is, to me, so much of this is dominated by SPECT. PET has a very small role to play, and even in these examples we're not going to get any useful planning information from those gallium-68 studies. So really I see the future of SPECT is essential here. It's not going away anytime soon, and as I hope I've shown with the reconstructions that we're doing, we're still got a lot of potential to improve the reconstruction and thereby get a better estimate of the dosimetry. So where are we with our technology today? The tools are now readily available. We've got some longer lived traces, we've got quantitative 3D imaging, we've got voxel-based dosimetry, we require our cooperative patients, as I've mentioned, and we've got unanswered questions really about the radiobiology. Can we fractionate? How should we do it? Why does treating the patient every 8 weeks make any sense? I don't think there's any evidence around that. And this article from a European group from 2007 was sort of suggesting these are the things that we're going to need if we want to do good biology, radiobiology, and all these technical sort of factors. And when I look at it today, some decade or so later, I can really think that we've got most of those checked off. I think now the spatial resolution limits we're starting to address with the reconstruction. Some of these other things are still not addressed fully, but we are certainly starting to understand a lot of this a lot better. So I think the ducks are all lining up. We've got good quantitative spect, good partial volume correction possible, a better understanding, or we're starting to get a better understanding of the dose rate effects and biological effective dose. And we're starting to develop some clinically feasible imaging protocols. And the importance of that is, of course, if more people, more institutions can actually acquire data that can be useful, will generate a lot more evidence to understand how to use it better. There are increasing opportunities for personalising therapy based on these tools. We are really also yet to explore multimodal treatment with PRRT. We're still giving as a single modality, whereas we could be combining it with chemotherapy, for example. And we've just completed a study in Australia, a multi-centre study, looking at combining lutate treatment in small bowel and pancreatic neuroendocrine tumours with capecitabine and temozolomide, so-called CAPTEM. And that's called the ControlNet study, and that's being analysed at the moment. And that'll be a very interesting study when we see the outcomes there. And the other thing is, we should be aware that radionuclide therapy is set to increase. And what I want to leave you with is something that sent shivers up the spines of the external beam radiotherapy companies. This is a slide from the Astro meeting, the American Society of Radiation Oncology, from 2019, where the NIH presented a session about where they saw radiation therapy going. And based on the analysis of the number of clinical trials underway at the moment, they came up with these predictions that cancer treatment is going to move from being anatomically guided, such as ZBRT is today, to a biological focus. And they saw that molecular radionuclide therapy is projected to account for 60% of total radiotherapy by 2035. Needless to say, since this slide was presented, I've had an increasing number of inquiries from companies such as Varian and Electa about understanding more about radionuclide therapy. It's clearly an area that they think that they want to be playing in and getting into. And of course, there was the announcement just a month ago in June 2020 that Varian had been bought by Siemens, so they're now taking over that company. So I think there's a lot of activity in this space to come, and the tools that we're developing today, the biology that we're trying to unravel today, is going to be vital to optimize the radionuclide therapies in the future. Thank you, and I hope this has been of interest to you.